antiretroviral drug, which was really a massive breakthrough as well. Retrovar, which is also called azidothymidine or zidovudine nowadays, was the first use was reported in 1987, and with that we saw a significant improvement in quality of life of patients who had AIDS. And around that time, the survival or life expectancy of a patient with a diagnosis of AIDS was between, 6 months and 12 months.
Yes.
And so it was almost like a death sentence around that time. So the introduction of zidovudine, improved quality of life, and then life expectancy a bit improved
for the patient.
For the patients as well.
Okay.
And around that time, we saw that the number of patients presenting with what we call opportunistic infections and cancers as well decreased. The quality of life of patients with HIV slightly also improved. And around 1994 again, that is when we saw the use of this same single agent, which is called zidovudine, for the prevention of mother-to-child transmission of HIV, because we had already seen that, a significant proportion of children born to HIV-infected mothers were developing, HIV infection. So there was a move towards, preventing mother-to-child transmission of HIV, and we showed that this single agent was able to retard or reduce the incidence of HIV infection among children born to mothers who are infected with the virus.
Dr. Bongmin.
Yes.
We hear that COVID-19,
Yeah.
and just like other viruses,
Yeah.
they have strains and variants.
Yes.
COVID-19 is just around 24 months or something.
Yeah.
But they are a number.
Yeah.
How much is there on record in
Yeah.
as far as HIV is concerned, in
Yeah.
terms of strains or variants?
We cannot clearly point that we have this number of strains of HIV, but we know the HIV virus has several mutations,
Okay.
but there's no clear number that you can say we have this kind of number as well.
Okay.
Yeah.
But do they treat a patient the same way, or some have weird symptoms and they actually strain or stretch the body in different ways?
In different ways. I think, like I've already alluded to before, the biggest issues related to this strain is really resistance to antiretroviral medication. And therefore, you find that someone who was doing well on one regimen of antiretroviral drugs, at some point becomes less responsive to this drug, which he or she was doing well on. And that probably is because of, strains, the new strains or coming in. But otherwise, if a strain is still susceptible, what we call susceptible, to the given antiretroviral regimen that the person is taking, then they continue to do well. But the big issue is that we have strains that may develop resistance. Yeah.
Okay.
Yeah.
How do I get these strains, for example?
Yeah.
If I'm already positive,
Yes.
do I need to engage a positive person and get a different strain, or I got you well that it develops itself on its own within my body?
Yeah, so both of those two possibilities, both of those are actually possibilities as well in these settings. We have what we call primary resistance and then secondary resistance. So a primary resistance, you already have a strain which is resistant to a particular drug or class of the antiretroviral drugs. A person, for example, who maybe has HIV-2, for example, they're already resistant to that particular, to a particular class of drug, for example. So really, you cannot use such drugs for them. And then there's what we call secondary resistance as well. Secondary resistance occurs in person who, initially, the drug, the virus was responding to this drug, okay? But then because of several factors, one of which being, someone not being adherent to the drug that they are taking, and then other mechanisms as well, which can render these viruses not to respond to the to the medication. But I think the most important is, a person not taking their medication the way they are supposed to, the way they are supposed to take.
We shall look at that
Yeah,
as well.
yeah, thank you.
In a general outlook,
Yeah.
internationally
Yeah,
and back home here,
yeah,
how successful are you, the medical people,
yeah,
in as far as fighting the HIV scourge is concerned?
yeah,
The guys in the social direction have done a lot.
yes,
They've taught people on how to prevent, taking social measures, abstain, do this, stick to one partner, and all that information.
yes,
You people in the medical world,
yeah.
how much effort have you laid on table?
On table, I think really there has been tremendous advances in the both diagnosis, prevention, and treatment of HIV at all axes, really, and we have to applaud the medical world for that. You know, as far as prevention is concerned, so much as there has been a social dimension already, which I don't really want to talk about, but there has also been an important medical dimension attached to it. Of course, the most obvious one is the voluntary medical male circumcision, which we have seen also already has taken, you know, the uptake of voluntary male medical circumcision has been, you know, nationwide and as well in other countries. So that is one big advances as far as prevention of HIV is concerned. And then, of course, two is antiretroviral medication as well. You know, I was talking about a single agent, zidovudine, being used in 1987.
Yes.
But now we have more than 30 individual ARVs that can be used, you know, belonging to various classes. We are talking about nearly 7 classes and about 4 different targets that these ARVs actually target. So, so that is really a big advances as well. And now we have also made advances in, you know, how to diagnose HIV quite early, and then, you know, after diagnosing, initiation of appropriate treatment, and then also we have made advances in monitoring response to treatment, either using your the viral load, knowing how much HIV you have in blood, or, you know, the CD4 count, which we used to use quite a bit for some time.
Okay.
Yeah.
You're talking about treatment, the
Yes.
terminology.
Yes.
Has it saved lives as we would really expect?
Yes, I would say yes, because in the past 40 years, we have seen about 80 million people being infected with HIV, 80 million in
Yes.
40 years. And if we are to look back again, we see that about 37 million deaths has also occurred in the past nearly 40 years. So, so you can see that over half of people, if you do that math, over half of people who got infected with HIV actually have survived or are still living with HIV, though up to about 37 million people have really died of the disease. So over time, you know, especially with introduction of what we call now combined antiretroviral therapy, where instead of using just a single antiretroviral agent, now we use a combination of 3 agents that you can take at the same time. And in some cases, you know, you have a single pill combining all these different antiretroviral agents. And that has, you know, tremendously improved the quality of life and survival. Now we can talk about people with HIV having nearly the same life expectancy as people without HIV. And so really that is a tremendous improvement in HIV care.
I want to bring you home.
Yes.
How would you rate our performance in terms of treatment?
In terms of treatment?
Yes.
Yeah. So first of all, we have to be, you know, very excited that Uganda as a country was among the only 8 countries in the world that achieved the UNAIDS 90-90-90 target. The 90-90 target, you know, means 90% of people with HIV should know their HIV status. And in Uganda, we are happy to say that up to 91% of people who have HIV actually know their status, that they have HIV. And then the other 90 aspect is that 90% of those who know that they have HIV should be on antiretroviral therapy. And we are also very excited to know that in Uganda, we also have 90% of patients who have HIV on antiretroviral therapy. And then the third 90 is that, you know, of the 90% that you have initiated on antiretroviral therapy, 90% should be having undetectable viral load in their blood. Okay, I think that is where we are a bit low. We are at 82% of person living with HIV achieving virologic suppression. But overall, it is really a tremendous success as well in HIV treatment in Uganda.
Okay, that is now good news.
Yeah.
I'll take you back a little to do with ARVs.
Yes.
How are our people responding to usage of those drugs here in Uganda?
Yeah. So still, that is similar to what we have just said. So I think, you know, there has been a great uptake of HIV treatment in Uganda, and as well as, you know, uptake of many HIV diagnostic programs as well in the country. So generally, I think it has been okay. It has been okay, people though we still have.
People have responded.
Yeah, people have responded to HIV services, and I also think you know, there are many things that have gone on well, except for, you know, recently we have seen the surge in the COVID-19 pandemic as well, and that has retarded the number of people going for HIV testing. I think it has reduced by over 40%, and also the number of people who get referred for, you know, HIV treatment and other services as well, and that has retarded our progress as well in the past year.
Okay.
Yeah.
Now, let us look at ARVs themselves.
Yes.
Can you just break down a little of what do they do in someone's body?
Yeah.
A body that has been attacked by HIV.
Yeah.
What do ARVs do in that particular body?
Yeah.
To give it the strength and things like that. Technically, what happens in there?
Yeah. So really what ARVs do, and that is what I told you, one of the progress that we have had in medicine is, you know, understanding the life cycle of HIV, because it is through understanding the life cycle of HIV that then you can put the ARVs to target specific points in the life cycle of the virus. Okay, because we know that you know the virus infects cells. Okay, and so the first step is that it has to bind to the cell. Okay, after binding to the cell, it has to enter inside the cell, and then it uses our cellular mechanism within the cell, you know, to replicate, to multiply, and then after multiplying, it enters into our own DNA. Okay, after entering into our own DNA, then, you know, our DNA usually replicates. Okay, it replicates, and then while your cells are replicating, the DNA of your cells are replicating, it is also HIV virions are also popping out, and then the virions are translated into proteins, and then those proteins are, you know, organized into vesicles as the virus, and that bursts off as well out of the cell. Okay, and so therefore the ARVs that we now have, they target all those stages. They target fusion of the virion of the HIV virus onto the cell. They target its, you know, reverse replication. It changes from an RNA into a DNA. So that is what we call reverse transcription. There's an enzyme which facilitates that reverse transcription from RNA to DNA, and then that DNA, you know, incorporating into your DNA. So we have again another drug that targets that, and then, you know, translation of the proviral DNA into messenger RNA and then proteins. So those are the different steps that the ARVs really target. And therefore, because of the several steps that are involved in HIV replication, also when we are treating HIV, we give these 3 drugs, okay, which target the different stages of the viral replication, so that you're having a more effective way of controlling the virus, but also minimizing the way the virus evades your drugs from acting. Yeah.
At what stage do you think somebody should start taking their ARVs?
Yes, so you know, that has been a debate for a long time, up to the early 90s. You know, when ARVs had just started being widely distributed across the world. So we saw that, you know, several trials as well were done to assess really when to start antiretroviral therapy.
Yes.
But because around that time in the early 90s, the issue was really not, the issue was around availability. The drug was not widely available, and then also the experience with the use of antiretroviral therapy was not up to date. So so trials were done, you know, to see whether you start ARVs when CD4 is less than 500 or less than 350 versus immediate study.
Which is a challenge, because how would an ordinary me get to know whether my CD4 is above this or lower than this?
Yeah. So now what we do really is, maybe let me talk about the present. So when a diagnosis of HIV has been made, you know, one is that, you know, you need to assess for readiness to start antiretroviral treatment, because, you know, this is a lifelong treatment. So the person who is going to take has to be ready, you know, to swallow this medicine.
How do you assess readiness?
Yeah, so this usually involve management of HIV is not based on a single individual. I can't say me as a doctor and I have you in front of me and then it is only my responsibility. It is a multidisciplinary approach where, you know, you have the nurse counselor, you have the pharmacist, you have the clinical team as well working together. So because, you know, if someone is not ready to swallow your medicine, then they will not take. And there's a simple saying that, you know, medicine does not work for people who don't take them. So even if you give them the medicine and they don't take that, then, you know, it will not do what it is supposed to do.
Okay.
So you first have to assess that, you know, this patient is ready to take antiretroviral drugs. And then after that, you assess for baseline blood tests. You know, how is their viral load? How is their, you know, their CD4 count? Do they have any other co-infection that already they have at hand? Do they have TB? Do they have cryptococcal disease? Do they have any hepatitis B, hepatitis C, or syphilis? All those basic screen. You know, how is their kidney functioning? How is their liver functioning? Because the drugs also have side effects. So, you know, you don't want to give a drug that may injure the liver in an already injured liver. So those are the things that you really want to assess. And then, you know, but by and large, if the patient is ready to accept...
that is the primary stage.
Yeah, the primary stage is that you have to assess this patient really in totality for acceptability, but also for their organ function and as well.
I already see a problem.
Yeah.
Do you think all our people take these tests, just as you have mentioned, many as you have mentioned, before starting these drugs?
Yeah, so ideally all these patients are supposed to take, and I'm sure.
But do they, in the practical sense, do they?
Maybe
checking the kidney, the liver and all that.
Yeah, that should actually be done. In some settings, I mean, this is done. Maybe in some other settings, you know, they may
because that's the right way.
Yeah.
I'm looking at our people in the rural settings where such services may not be available.
Yeah.
And we already having a problem there.
Yeah,
in that particular area.
I agree that is a challenge. But we always encourage, whenever possible, all these evaluations, baseline evaluation should be done to avoid toxicities related to the drug in the future.
Is it right for somebody to get to start these drugs when they are already very ill and weak? Can they help them?
Yeah, and that is the challenge that we see as well, because globally we have seen that, you know, up to a third, 1 in 3 of patients, especially who present to the hospital, they already present when they have what we call advanced HIV disease, with already, you know, opportunistic infection. They already have very bad tuberculosis. They have disseminated cancers and so on. Okay. So in such scenarios, we still encourage that, you know, ARVs. You understand? Because someone may have been having already HIV for 10 years, for 5 years, okay? But in most cases, what brings them to the hospital are what we call opportunistic infection,
Yes.
or opportunistic malignancy, or adverse events related to the drug that they are taking. So those are the things that you really want to identify early and address them appropriately.
You talked about side
Yeah.
effects with these drugs.
Yeah, yeah.
I've heard of so many people that end up with kidney issues,
Yeah.
heart problems, issues to do with the liver. How would you look at that? Because trying to solve a problem and again cause more problems.
Yeah. So
Is there a way somebody can counter these possible side effects as they take their drugs?
Yeah, so there are two issues. First of all, I have to say that the benefit of antiretroviral therapy outweighs the risk of adverse events related to these drugs. Okay, so definitely you benefit from the drugs more than their side effects. They occur, but in a smaller population,
Okay.
of this patient, and that is why I also said initially, you know, you need to do baseline investigation, check the patient's kidney function, check the patient's liver function, so that you know you are not pouring salt on a wound.
Thank you so much, Dr.
Yeah.
Bongomin.
Yeah.
To you watching, we are discussing HIV, but in the sense of medication. How much have we achieved? How much can we benefit from what we have achieved in terms of treating our people and keep them alive? All of us, not just anyone else. So that's what we are discussing, and we have a specialist in internal medicine, Dr. Felix Bongmin here, and he's giving us a lot of information. Please do not go anywhere. On return, we have more. Let's enjoy this break.
Patriotism is a feeling of love, devotion, and the willingness to sacrifice for one's country.
I say no to corruption because I put my country first. I choose peace over violence because I put my country first.
I love Uganda. I serve Uganda. I sacrifice for Uganda. I'm loyal to Uganda. I love myself.
Be patriotic. Uganda first. This message is brought to you by the National Secretariat for Patriotism Co Uganda, Office of the President.
UBC One-on-One with Micheal Jordan Lukomwa. Thank you so much for keeping it with us. If you have just joined, we are giving out this 1 hour to the worst scourge the world has faced, in my view, and that is the HIV and AIDS, having commemorated its day this week on Wednesday, the 1st of December. We have children
Yeah.
that are positive,
Yeah.
infants, children, and the young people.
Yeah.
Do young bodies take the same ARVs like the adult bodies? And even then, aren't there side effects if they take the same drugs, adult bodies and these young bodies?
Yeah.
How do you handle the side effects?
So that is really a very important point, because children also contribute to a significant proportion of people living with HIV.
Yes.
Globally and in Uganda as well. First of all, we have to appreciate that in the past 40 years, we have seen a tremendous decline in mother-to-child transmission of HIV. So the population of children with HIV or living with HIV has drastically really reduced in the past years, thanks to, again, antiretroviral medication being widely available and prescribed during pregnancy. Now we are looking at, elimination of mother-to-child transmission of HIV,
Yeah.
where, you know, in some settings, really, this is less than 1% from over 25% 30 years back. So, yes, your question is really very important as well, because most of the studies involving antiretroviral medication are really done in adults. And then some of the evidence are then translated as well in children.
Is that a problem?
Yeah, that is a problem. That because you know we are just
These are two different types of
There are two
bodies.
different populations. But again, and in medicine, the good news is that for children, really we use their weight to determine what medication they get. So even when in adults, you know, it is a standard regimen, a standard drug that, you know, for example, if you are taking coartem, then you know you are taking 4 or something like that. Then, but in children, we use their weight to determine what
is right for them.
what is right for them. Okay. So in most scenarios, therefore, the medication that are used for treatment of HIV in children is the same as that of adult with some modification here and there, but the dose is based on their weight. Okay? So they don't take the large dose of the medication as adults do. They take what is appropriate for their weight.
Okay.
Yeah.
What mistakes do we make
Yeah.
as we consume these drugs?
Yeah. So I think one of the biggest issues related to antiretroviral medication in our setting really is not adhering to the drug. You know, your doctor tells you, take this medication every day at a chosen time of your convenience. You know, some will dictate based on the side effect profile of the drug that, you know, the drug is better taken in the morning with breakfast or with food, or it is better taken at night, or better avoided at night based on this, the side effect profile as understood by the scientist, by the clinician. Okay? But then you find someone, you know, not taking the medication as prescribed by the, or they're taking a drug holiday, for example, you know, 2 weeks, 3 weeks, 1 month, 6 months, they are not taking really this medication. Therefore, like I said before, drugs do not work on people who don't take them. So, and that is how patients, therefore, do not have, you know, suppressed viral load, and then they keep on getting several opportunistic infection and cancers as well. So,
That's on the side of the patients.
Yes.
You medical people,
Yeah.
what mistakes do you make when
Yeah.
handling HIV patients?
yeah. So I think one of the big issues, you know, preparing the patients to receive this medication. You know, you need to counsel these patients. You need to talk to them. You need to prepare them psychologically, and you also need to prepare them physically, assessing, you know, their drug-drug interaction. You know, what other drugs are these patients taking? What other comorbidities do they have? Do they have diabetes, hypertension, and so on? Because all this will as well impact on your choice of antiretroviral therapy, but also how the drug will work on the patient. So all that you have to really put into consideration.
Some come for drugs, and today you're not there. This is the day she had to come back, or you had to come back,
Yeah.
and then you didn't come. Like
Yeah.
some of you who treat our people in the rural areas.
Yeah.
There are days you are there, and the days you're not there. So
Yeah.
they come, they get stuck at the health facilities.
Yeah, so I think that has really been sorted, because unlike the olden days, nowadays we have dedicated HIV clinics, which, you know, offers almost a 24/7 services to people living with HIV. So I think really there has been advancement, and that shouldn't be a big problem.
Okay.
For now, yeah.
Where I'm now taking you is a lot of where we get information either wrong or right.
Yeah.
And having you is now an opportunity.
Yes.
There is information that somebody that has taken their drugs effectively,
Yeah.
at a certain point, they cannot infect anyone.
Yeah.
How true is that?
Yeah, that is absolutely true. And again, those are some of the advances that we have seen in HIV treatment in the past few years. You know, usually those days prevention used to be the ABCD. You know, abstain, be faithful, and then use condom. But now we have seen that treatment itself can also be used as a form of prevention.
Really?
Because studies have shown that, and these studies have been conducted in people who are discordant, serodiscordant couple, where, you know, one person is HIV positive, maybe the wife is HIV positive or the husband is HIV positive, but the wife on the other side or the husband is HIV negative. And studies have been, and some of these studies have actually been done in Uganda, recruiting patients from Uganda and Kenya as well. And we have seen from these studies that, you know, for patients who are in serodiscordant relationship, the person who is HIV positive, the person who is HIV positive, if their viral load is undetectable, they are not able to transmit HIV to the HIV negative partner in that relationship. And that is now the new concept, which we call U equals to U, which means undetectable equals to untransmissible. And so that is, again, another very important observation that we have seen in HIV care.
So it is true. At what point does this person become, go to that level where they cannot transmit?
Yes.
For example, is it somebody that has swallowed 3 boxes of drugs, somebody that has consumed drugs for 10 months, at what rate? Or it is told after some tests are taken?
Yeah, so definitely some tests really have to be taken. So usually what we do in HIV care is that once a person is diagnosed with HIV, they have been assessed for readiness to initiate antiretroviral therapy. Then we start these patients on antiretroviral drugs. Then we schedule regular visits, okay? Maybe 1 month, 2 months, depending on the settings. And then at 6 months, we take blood sample from this patient and then do now what we call a viral load and then see. So for most patients who will be responding well to antiretroviral drugs, by 6 months, they already have viral load less than 1,000.
Okay.
You understand? And then for those who do not have viral load less than 1,000, you know, you assess for adherence, because in most cases they are really not adhering to their medication. And if you find that they are not adhering to their medication, these are the patients you want to offer to what we call intensive adherent counseling, you know, to improve their adherence to the medication. And by 1 year, we expect a significant reduction in viral load, and in majority of patients, you know, you will have their viral load undetectable. And these are the group of people we are talking about, okay? So they must have been on antiretroviral drugs for at least, I'm talking about 6 to 1 year. And then
6 months to 1 year,
effectively? Effectively, when you are taking the pills every day without missing.
Okay.
Yeah.
Such a person cannot infect anyone.
Yes, if you determine that they are virally suppressed. Their viral load, their HIV viral load is undetectable.
But I want to emphasize this. It is the doctor to tell.
It is the doctor to tell, not
after
the patient.
taking tests.
After taking
not
tests.
Not me looking at you and I say, but now after 6 months you will not infect me.
No. A viral load has to be checked.
By the doctor.
By the doctor.
Wow, thank you so much for that information.
Yeah.
Now, there is still some other misinformation about discordant couples.
Yeah.
That if my partner is positive and they are taking drugs, then I can do anything with them even if I'm not taking any precaution.
Yes. So again, this goes back to, you know, what we were talking about. Undetectable equals untransmissible.
Yes.
So for this discordant couple, so long as the HIV infected partner is taking the ARVs as prescribed and is virologically suppressed with undetectable viral load, then we do not expect, you know, the HIV infected partner to transmit to the HIV uninfected partner. And like I told you, this study, this landmark study, was actually done recruiting patients from Uganda. And of the few patients who really developed HIV infection in a serodiscordant couple, you know, further studies actually revealed that most of these people who got HIV infection actually got it from extramarital affairs, but not from this serodiscordant relationship.
Okay.
Yeah.
Something still to do with the discordant couples.
Yes.
So what treatment are they given to keep a happy family? The negative partner is negative throughout,
Yeah.
and the positive partner is living a good life,
A good life.
healthy and happy.
Yeah.
What treatment is given to the? What treatment is given to them,
Yeah.
and what do our people need to know?
Yeah. So that is important question as well.
Because in our social life,
Yeah.
when a couple, one of the two tests positive,
Yeah.
everybody will tell you not even to go back home with this person.
Yeah.
So, what treatment gives hope
Yeah.
to these couples in the medical kind of sense?
Yeah. So first of all, there is really no special there's no special antiretroviral therapy that is given specifically for discordant couples. You know, the same ARVs that we use in the general population is really what is also given to a person who is in a discordant relationship. I think the only key issue is that, you know, if you control viral replication in the HIV seropositive partner, then you are able to, you know, halt transmission to the HIV seronegative partner.
Okay.
So the same regimen, really.
Okay.
Yeah.
How much have we achieved the prevention of mother-to-baby transmission? You talked about it, but I want a detailed kind of picture.
Yeah.
As Uganda, how much have we achieved in that prevention of mother-to-baby transmission?
I
Yes.
think there has been tremendous improvement in the mother-to-child transmission of HIV. And we have seen, you know, the numbers decreasing in the past 10 years, from 2010 to 2020. And currently, the number stands that mother-to-child transmission of HIV is about 5 you know, children living with HIV due to mother-to-child transmission of HIV is only about 5.85%. So it is less than 6%.
What explains that 5%?
Yeah.
Having achieved almost 95%.
Yeah. So again, so these are some of the things, because we know mother-to-child transmission of HIV occurs either during pregnancy, around delivery, and during breastfeeding.
Okay.
So that means, you know, for you to effectively eliminate mother-to-child transmission of HIV, that means, you know, all mothers, first of all, have to know their HIV serostatus even before getting pregnant. Okay? So if you miss the opportunity to diagnose HIV before pregnancy, then, you know, mothers are encouraged, all mothers have been encouraged to attend antenatal care. And during routine antenatal care, one of the most important tests that is done is HIV test. So therefore, early diagnosis of HIV during pregnancy and initiation of antiretroviral drugs during pregnancy, you know, halts transmission of HIV from mother to the child. And then during deliveries, you know, you want to encourage these mothers to deliver from the hospital rather than being attended to by the traditional birth attendant.
Yes.
So that you have deliveries within the health facility, and that, you know, will decrease
That professional touch.
yeah, will decrease transmission to the child. And then, you know, post-delivery, you know, this child should be in touch with the healthcare providers. And then you make sure that other preventive medicine, much as the mother is taking antiretroviral drug, the child is also started on preventive antiretroviral medication, you know, so that it reduces, because we encourage these mothers as well to still breastfeed their children, so that, you know, the child is taking antiretroviral medication also to reduce the rate of transmission during breastfeeding. So those are some of the steps that.
How safe is that? This child being
Yeah.
breastfed by a positive mother.
Yeah, so again, those used to be, debates of those days. Those days they say if a mother is HIV positive,
Yes.
after delivery, the mother should not be what? Should not be breastfeeding the child.
Actually, that's what we've been knowing for all along.
You understand? But over the time, we have seen that breast milk. There's no substitute to breast milk.
Okay.
Ideally, there's not this artificial or cow's milk or something. Those cow's milk is meant for the calf, for the cow, for the young cow.
Yes.
Yeah.
Not for a human
Not
being.
for a human being. So for human beings, we know the colostrum, which is has a lot of nutrients. It is good for the child. And then we have seen that several children end up with malnutrition if they have not been breastfed by their mothers. So the risk of not breastfeeding the child and the complication that comes with it, was really more than was really more than the benefit of discouraging these mothers to breastfeed their children. So now, as we talk, we have substantial evidence to prove that breastfeeding
It's not as risky.
is not as risky as leaving the child not to breastfeed.
So how do
Because-
we protect the baby as he or she
Breastfeeds,
gets
yeah.
breastfed by this positive?
And that is what we are saying. The mother has to be on antiretroviral therapy. That reduces the viral load.
Okay.
The child has to be on antiretroviral medication that we also give after delivery, so that the combination of antiretroviral therapy for the child and for the mother drastically reduces the viral transfer from the mother to the child.
Okay.
Yeah.
Thank you so much.
Yeah.
I'll now take you to another area where we have a lot of misinformation.
Yes.
That is PEP and PrEP.
PrEP, yeah.
We have looked at it in those other areas we discussed, but
Yeah.
here I want to look at it in an independent form.
Yeah.
What is PEP?
Yeah. So PEP and PrEP. So I think because these are abbreviations, so we
Yes.
need to
Actually, I wrote them in the abbreviation form so that somebody can understand, from
yeah.
the real explanation
Yeah.
of
Yeah.
the synonyms.
So PEP, the first P is called post.
Yes.
The E is exposure, and the other P is prophylaxis. Prophylaxis is like prevention. So prevention after exposure. So we are talking about, high risk events. Someone who is HIV negative. Okay? You are HIV negative, but you have had a risky exposure to HIV.
Yes.
We are talking about needle stick injury among healthcare workers, for example. You are treating a person living with HIV, and then by mistake, you have just from withdrawing blood from this patient, and then you prick yourself. So that is called a high risk behavior. We are talking about a person having unprotected, a condomless sexual intercourse with another person with whom they do not know their HIV status.
Yes.
Or they know that the person is HIV positive, but they still had a condomless sexual interaction. Or we are talking about sexual assault. Someone is being raped by an HIV positive person, or a person with unknown HIV status. So those are the high risk exposures that we are talking about.
Yes.
So in such scenarios, you want to start that person who is at a high risk on antiretroviral medication, complete regimen composing of 3 drugs, but for a shorter period of time. We are talking about 28 days, okay? And after exposure, you really want to start this patient on PEP as soon as possible, and not later than 72 hours or 3 days, because the earlier you start this PEP, the higher you are likelihood of reducing the risk of acquiring HIV infection. So really that is
So
what
PEP is for prevention
yes,
after you have had a situation that exposes you to acquiring HIV.
yes, high risk exposure.
It has to be taken in not less than 72 hours
Yes.
of the exposure.
Of the exposure, and taken for a total of 28 days.
Thank you.
Yeah.
I'm told these drugs, the pluck off people's hair, they have side effects because they are too strong to fight a very strong virus, so they shake the body.
Yeah.
How true is that?
Yes, again, you know, someone once said, a drug that has no side effect has no effect. So every drug, definitely, that we use in the medical world, at least they have some side effects.
Okay.
But you know, some of these, some side effects are life-threatening, some side effects are really mild to moderate.
Give us a picture about these ones to do with PEP.
Yeah, and there is no exception also to these drugs which we use for PEP as well. You know, so some of the drugs that we use for PEP, of course, they will give you the general side effects that we are talking about, nausea, we are talking about vomiting. And some patients, you know, you'll end up with some yellowing of the eyes for some specific drugs. Some may be related to liver injury, but some may not actually be related to liver injury. There are some agents that may affect the kidney and the bones, and also they may affect your blood cells. So patients may present with low blood count, with anemia, as side effects to this drug. But or you know, someone may end up with a new onset very high blood sugars, which may end up in diabetes or weight gain. But again, these side effects are not very, they occur, but not in really high proportion.
That is on both sides of PEP and PrEP.
Yeah, PrEP is...
Because I want us now to explain PrEP.
Yeah, because PrEP is a bit different, but we still use kind of the same drug. So I think the similarity between PEP and PrEP is that both of them, you know, are used in HIV negative population.
Exactly.
But for PrEP, PrEP stands for pre-exposure.
Yes.
Remember, PEP was post-exposure. So this one is pre-exposure prophylaxis. You know, you are taking the drug even before exposure to HIV, to the virus. So we are talking about, you know, someone who is a commercial sex worker, for example. They know at some point, either today or tomorrow, they may be having a sexual encounter with a person with whom they're not sure of their HIV status. You know, we are talking about a long-distance truck driver. Yeah? And many other populations. We are talking about someone who injects a drug, for example. You know, they are not sure who they are going to share their needles with. So PrEP really is you want to take to prevent future high-risk exposure. Yeah.
So PrEP is for prevent before you go
before even you have the end.
As PEP
is after
the
you have already
exposure.
had high-risk exposure.
Thank you so much, Doctor.
And then I think the other thing is that, you know, for PrEP, we use only 2 drugs. Meanwhile, for PEP, we use 3 drugs in combination.
Okay.
Yeah.
We had stories of Uganda trying to come up with a vaccine for HIV and AIDS.
And AIDS, yeah.
Is it true?
Yeah.
How far?
Yeah. So again, that is a very important issue. So there are really 2 important developments that are going on. 2 very important studies that are going on. We have the one which we have to definitely talk about. You know, is the injectable antiretroviral drug.
Yes.
And then we are also talking about the vaccine. Okay. All of which are under clinical trials, where the vaccine trial is taking place in Masaka. They are recruiting patients from Masaka district, and that again employs a combination of PrEP and the vaccine.
Okay.
Yeah. So it is called the PrEP-Vac trial. So they want to establish that. And up to now, you know, we have seen recently in the news that, you know, they have recruited just over 150 participants. But this study is to run up to 2023. So for now, we don't have any results. So we just have to wait until recruitment is done somewhere between March
2023.
and 23.
Okay,
Yeah,
this is
yeah.
2021.
Okay.
So
we still have to wait until that time. And then also 2 months ago, we have seen patients being recruited again in another trial where, you know, they're evaluating if, you know, they're comparing you taking antiretroviral drugs every day versus getting injection every 2 months. Okay, and again, this we have seen from studies in Europe and America, where, you know,
that injectable is also a Ugandan kind of idea.
No, not Ugandan kind of idea, but people have evaluated this in the Western world, and it has been shown to work. You know, injection once a month or once in 2 months is as effective as taking this oral medication every day.
Okay.
And that has been well established, but not in the African setting. So we now think the study, the clinical trial being done in Uganda, will provide an African perspective to how we can effectively use this injectable medication as well. And because, you know, we have seen previously that, you know, patients get difficulties in taking medication, taking the pills every day. So, you know, if you are under stigma, people still are afraid of stigma and discrimination that they're taking, you know, antiretroviral medication. So if they're taking this just single injection every 2 months, I think that would improve adherence to the drugs, and that would also improve patient satisfaction with this medication and reduce probably side effects as well.
Okay.
Yeah.
Based on the information we have shared, there is a lot that has been achieved in the medical world in as far as HIV and AIDS is concerned.
Yeah.
Does it give you hope of one day having a cure of HIV and AIDS, or are there even trials for that?
Yeah, so again, that is something I really don't want to commit myself to at this point in time. You know, talking about...
But when you look at the achievements,
yeah.
do you see us there someday, sometime?
Yeah, definitely, because, you know, science stops when you stop being, you know, anticipatory for future development, you know. So hopefully one day we shall develop a cure for HIV infection, but for now, you know, there is no cure for HIV infection, and there is no vaccine for HIV infection. Everything is still under clinical trials. Okay. Though, you know, previously we have seen, I think it was at 2009 when there was some study, you know, showing some a bit of efficacy of HIV vaccine, but up to now, we still do not have a proper vaccine for HIV globally.
Okay.
Yeah.
Thank you so much, Dr. Felix Bongomin. You are an internal medicine specialist. You said house member?
Yeah, senior house officer in internal medicine.
Senior house officer in internal medicine attached to Makerere University.
Yeah.
We thank you so much for all the information you have shared with us. Send my greetings to Professor Biachika. It is through her that I managed to get you.
Thank you.
To you watching UBC TV, as the day was designed to reflect on this big problem the world has grappled with for over 40 years, take this program in that kind of spirit. Whatever we have shared is for your own good, for our own good, to reflect on it and do the right thing for the good of your life, your family, your community, and the beautiful Pearl of Africa, Uganda, and the world at large. My name is Micheal Jordan Lukomwa with Davis Kamukama, my cameraman, Gloria Guitavinji, and the whole team. Wish you the best of the night. Stay safe. AIDS kills, and it's still here. Bye-bye.
Our core is that all people coming to our health facilities in the country are screened to rule out active TB disease, and those with disease are provided treatment as part of the services being offered.
Those living with the disease need our support as members of the community, adherence to treatment requires a lot of community support. And of course, even putting a stop on transmission of this infectious disease, TB, requires a lot of community response.
Together, united, we would want to ensure that no case of TB goes undetected.
Seek treatment, and the treatment is available free of charge, and ensure that you complete all the 6 months of TB treatment.
We call upon you to join hands together, to work with us to ensure that we put a stop to TB in the country.
I'm glad to inform you that the Ministry of Health works